or personalized way or individualized way. She'll use several terms today. We'll learn more about this. This is an interesting blend of genetics, clinical work, and chemistry. And that's important because on this day in history, there have been a number of events that relate to this topic that I think you'll find interesting. Number one is that back in 1876 on this day, January 23rd, was the birth of Otto Paul Hermann Diels, who was a German organic chemist who, with Kurt Adler, who was his student, received the Nobel Prize for Chemistry in 1950. And they received the Nobel Prize for their work on the preparation of cyclic organic compounds. They worked on this development of these diene synthesis, which is basically taking compounds that have two carbon double bonds and how you turn those into cyclic compounds, which later on became very important. And of course, it's known as the Diels-Alder reaction because of the people who worked on it, and they won the Nobel Prize for it. The other event was in 1929, on this very day, was the birth of John C. Pulmonary. And Pulmonary was a German-Canadian chemist and educator who also won the Nobel Prize for Chemistry in 1986, and he shared it with Hirschbach and Lee for contributions of what at that time was known as a new field in chemistry, which was basically known as reaction dynamics. And what this group did was to study infrared chemiluminescence, which is so important today to evaluate the outcome of certain chemical reactions. My favorite was Gertrude B. Elion, which was born on this day in 1918. And she was an American pharmacologist who shared the Nobel Prize for Physiology or Medicine in 1988 with Hitchens and Sir Black for the development of a number of drugs that are important for cancer and for the treatment of rejection after transplantation. And we all know these drugs. I'm talking about 6-mercaptopurine, azathioprine, allopurinol, trimethoprim, acyclovir, all through the work of Gertrude Elion, who was born on this day, January 23rd, in 1918. And with that, I bring you today Kristen Healing Reynolds. I'm still in my Spanish mode this morning. So Dr. Reynolds is from our house. She is the VP of Lab Operations and Associate Medical Director of Pharmacogenetics Diagnostic Laboratories. She's Assistant Clinical Professor of the Department of Pathology, and her focus is pharmacogenetics, and that's why she's here today, so that we can learn about this. She obtained her degree in biology in 1996 from Bellarmine University, joined University of Louisville, and obtained her Ph.D. in microbiology and immunology in 2001. And she did a number of postdoc fellowships in this area, which she's going to talk to us about. She has grants from the NIH on personalized medicine. She's reviewed for a number of journals in the area of pharmacogenetics. She's won the Young Investigator Award for the Association of Clinical Chemistry in 2007 and 2012. And she's won the Outstanding Speaker Award from the same organization. So we're very pleased to have Dr. Reynolds today and learn about this field and how it is moving. And Dr. Reynolds, a reminder that says here, your paper says, turn on the microphone. Welcome.
Okay. Thank you very much for that kind introduction. I'm really happy to be here today. I have one other date in history about this day. On this day, January 23rd, was born my mentor, Dr. Mark Linder, who is one of the absolute pioneers in the field of pharmacogenetics, and I have been lucky enough to serve with him in the PGXL Laboratories. So happy birthday, sir. Okay, a little bit of primer. Adverse drug reactions. Leading cause of death in the United States, one of the top 5 leading causes of death in the United States. And what is important to understand about this particular fact is that these are reactions that are caused not by a patient being given the wrong drug. These are patients who are candidates for the medication being given what is considered sort of a conventional dose, but who have a severe, even fatal reaction to it. Now, what we know about these ADRs, 60% of the drugs that commonly cause these severe ADRs are linked to a genetic polymorphism. So there's an enormous amount of information we have to be able to identify risk associated with these severe ADRs. Over 122 drugs now have labels related to the drug and a genetic biomarker of some sort. The FDA is definitely recognizing that as we learn more about outcomes and effectiveness of these genetic biomarkers, that they are in fact linked to safety. And we have a lot of different label changes to old medications as well as new biomarkers with newly approved medications just in the last 4 or 5 years. And I'll highlight a few of those for you today. So these are the drugs that are commonly associated with, let's make sure we get that one working, associated with hospitalizations, ADRs leading to hospitalizations. You probably recognize quite a few of these, perhaps in your own experience. Topping the list are non-steroidals, diuretics, warfarin, always in the top 3 or 4, depending on, no matter what study you read, warfarin is a big one. ACE inhibitors, antidepressants, beta blockers, opioids, et cetera, et cetera. And clopidogrel tops out this list at number 10. All the ones in red here, 60% of these guys actually have known genetic, pharmacogenetic markers that can help us identify patients who are at risk of having such ADRs. So 60% we can help you identify at the beginning. So just a little bit about pharmacology to make sure we're all on the same page. A little pharmacology 101 here. Every drug elicits its effect by binding to the corresponding drug receptor in a concentration-dependent way. That drug concentration at the receptor is balanced by the dose rate in and the clearance rate out. Clearance rate obviously being driven mostly by metabolism, hepatic metabolism in this particular case. We know that if we alter with a genetic variant, for example, a genetic variant in that drug receptor is going to alter the way that receptor can bind to the drug of interest, either by altering that binding pocket of the receptor and making it have less affinity for the drug, or simply by there being less expression of that particular receptor so that there's not enough of it available to be bound by the drug. Now, the other side of the coin is the metabolic side. And we know that genetic variants in the metabolic side will affect the clearance rate, will affect the half-life of that medication. So that's going to affect both a factor of concentration as well as time. So it's not only going to affect the dose requirement of that patient or the concentration required to achieve a therapeutic benefit, but it's also going to affect how long the drug sticks around in the blood. Again, I've got several examples of that. But I highlight this to help us think about how important it is to understand the mechanism of effect of a given genetic biomarker. If we know that one genotype, one variant genotype affects clearance, can decrease clearance of a medication, then we understand the fundamental consequence, the mechanism of action of that genetic variability leads to differences in dose requirement. Think about the way you would dose vancomycin, for example, in a patient with renal insufficiency. You give them less drug because they have decreased renal clearance. It's the same type of mechanism. Once you understand that mechanism, you have the ability to account for that altered drug clearance rate and give a difference in dose requirement. Okay. There are a lot of different applications of pharmacogenetics these days all over different fields of medicine. The 3 that have been very prominent in the last year or so, other than the field of oncology, which is huge, would be these: behavioral health, cardiovascular health, and pain management. This is really where we've been focusing in my laboratory, and certainly where a lot of laboratories and academic institutions across the country have been focusing. Vanderbilt, Duke, Mayo, they've all started programs. They're primarily focusing in cardiovascular disease with their implementation of pharmacogenetics. So right here in River City, we have a broad opportunity to be studying this for our patient population. Within behavioral health, I'll give you some examples here for helping to predict which patients are at increased risk of developing treatment-resistant depression, how we can better treat psychoses with optimized medication selection, antiplatelets, so mostly talking about clopidogrel there, or when it's better to use the alternatives to clopidogrel, and opioids within pain management. So let's talk a little bit about behavioral health. There are over 23 million Americans who are taking some sort of behavioral health medication. The number 2 prescription last year was Abilify. So we've got a huge opportunity with the amount of pharmacogenetic information we have in these pockets of medication classes. In anxiety and depression, we've got patients in the 50 to 60% range who are unlikely to respond to their initial antidepressant medication. And anywhere from 10 to 50% of all depressed patients become treatment refractory or treatment resistant at some point. Just sort of depends on which study you're reading at the time. Schizophrenia, bipolar, a lot of the other related psychoses. There are over 65,000 hospitalizations per annum. And the average length of stay for those patients exhibiting those exacerbation episodes is 7 days. If we can pick the right medication, the better medication for those patients at the beginning of that episode, or preferably before they even have the recurrent episode, we have the opportunity to increase stability, hasten stability, and decrease the costs and risks associated with recurrent episodes. Psychiatry medications, most of them are metabolized by cytochrome P450 enzymes, the very vast majority of them. Cytochromes are a group of enzymes in the liver that detoxify blood. The large ones, the big ones, clinically relevant ones, include cytochrome P452D6, which metabolizes about 25% of all medications. About 10% of the population are deficient, genetically deficient in 2D6. They have no residual 2D6 metabolic activity. So 10% of your patients will not respond to a quarter of all medications you would consider for them. So it's a pretty big assessment. The intermediate metabolizers are folks who have one normal copy and one abnormal copy, so they sort of fall into this gray zone of risk. They need probably lower than average doses, but not as low as poor metabolizers. And we'll get into this with some specifics. But as you can see, very, very common medications here with significant associations to known genetically polymorphic enzymes. So let's think about how we can, where we can implement pharmacogenetics, how you can begin to utilize the information. So if we think about something like an SSRI antidepressant, and the metabolic side of the coin, that pharmacokinetic implication is 2D6 for these guys. Most, but not all of them, are metabolized by that 2D6 enzyme. And we know that 10% of the population are poor metabolizers. These are folks who do not inactivate that SSRI, like, let's say, paroxetine. They take a standard dose of paroxetine. They don't inactivate it. They end up with more of the drug in their blood for longer periods of time. They're at risk of adverse drug reactions based on supratherapeutic drug levels. Extensive metabolizers, or EMs, are basically the normal metabolizers. These are folks that have 2 normal copies of the gene. They're the ones who'd be expected to take a normal dose of the drug and have an adequate response without an increased risk of having an adverse drug reaction. Now, the ultra-rapid metabolizers are about 3% of the general population. Ethnic background will vary that more, but about 3% of general. Ultra-rapid metabolizers actually have a genetic variant or a genetic duplication of that gene. So instead of having 2 copies, one from mom and one from dad, they actually have 3 or 4, or in some cases 13 copies of the 2D6 gene. They have more than normal amounts of 2D6 activity, so they take a normal dose of a drug, and they burn through it so quickly that they never achieve therapeutic blood concentrations of the drug. So those are folks who might need increased doses. But if you don't know whether the person is not responding because they have some other genetic resistance or because they're an ultra-rapid metabolizer, it's hard for you to really make a decision without trial and error. Now, the other side of this coin is the pharmacodynamic side. The receptor, the target receptor for SSRIs is the serotonin transporter in the brain. That's encoded by a gene called SLC6A4. Now, the serotonin transporter is what these SSRIs bind to and inhibit to elevate the serotonin levels and improve mood. There's a variant in the serotonin transporter gene in this SLC6A4 that causes there to be less of the transporter produced in the brain. If you have less serotonin transporter in the brain, the SSRIs don't have their target to go bind to and inhibit. So patients with this genetic variant actually are at increased risk of failing SSRI therapies. And there are several meta-analyses that have been done in the last few years that show a significant association to this variant genotype and risk of failing SSRIs. So we can understand, we can begin to incorporate both sides of the pharmacology of an SSRI and impact that continuum of risk, that long 16-week protracted period for a depressed patient. We can begin to understand why so many people have treatment refractory depression. When we think about the cytochrome deficiencies, we think this is a really great model. Okay, I'm showing here atomoxetine, but any drug that's metabolized by a cytochrome is going to have this type of effect. So if we look at a standard dose of atomoxetine or Strattera for a patient, maybe 20 milligrams twice a day, extensive metabolizers will achieve therapeutic blood concentrations of atomoxetine in the first couple doses. It's got a very short half-life, so they reach steady state blood concentrations. Remember, steady state is 5 to 7 half-lives of a given drug. And they'll reach steady state equilibrium in a few days. But a poor metabolizer of 2D6, so a patient who does not metabolize or clear this medication, taking the same 20 milligram twice a day dose, the first thing you'll notice is that their blood concentrations are going to be through the roof, roughly 4 times higher than that of the extensive metabolizers. But the more subtle thing is that delay in the time to reach steady state. Their half-life is 4 times as long, so too will their time to reach steady state. Steady state is the important time to remember that that's when the blood concentrations are reproducible. That's when the patient is stable on that medication in terms of concentration of the drug. That's the best time to be looking at whether the patient is adequately responding to that medication. The other thing that is important to understand about a delayed steady state or an increased half-life for a drug is how much longer it takes for that drug to wash out if you decide to discontinue the medication. So let's say this patient has very, very high blood levels. They begin to demonstrate adverse drug reactions. The physician wants to take them off the medication. It's going to take 4 times longer for them to wash out of that medication based on the delayed clearance. So if they wanted to start the patient on a new medication a few days after they discontinue the first med, they really probably should wait a week to 2 weeks longer just to avoid a potential drug-drug interaction unwittingly. But again, a good model for how to think about these pharmacogenetic, these metabolic variants. So what do we do about it? Again, if we understand that the functional consequence, that mechanism of action of that genotype is decreased clearance, and we understand what the half-life alteration is for that drug, we can calculate dose reductions for these patients based on that specific genotype, just like you do calculate altered antibiotic doses for patients with decreased renal clearance. And for atomoxetine, the package insert actually states give a 50% dose reduction. We look at that, model that out. Here's the poor metabolizer taking 20 milligrams. Here's the poor metabolizer now in red, taking 10 milligrams per day. We notice that the blood concentrations are right in the middle of the therapeutic range, consistent with where the normal metabolizers or extensive metabolizers are. And perhaps more subtly, we also notice that they have less fluctuation between their peak and troughs. So they are now stable in the therapeutic range, and they are now normalized to the risks of adverse reactions to those of the normal metabolizers. Aripiprazole looks the same way. This was from a paper we did a couple years ago, and the Abilify monograph actually says 2D6 poor metabolizers have increased blood concentrations, increased risk of adverse drug reactions, and should be considered for a 50% dose reduction. There's also a pharmacogenetic guideline out at this point that talks about aripiprazole poor metabolizers needing anywhere from a 33 to a 50% dose reduction. So it's not just a straight 50% reduction for everybody. There are genotype-specific decreases that we now have information for. So where we were 5 years ago, we could say the patient has a 2D6 poor metabolizer phenotype. They may need lower than average doses of a drug to avoid adverse drug reactions to that medication. Now we can say for a lot of these medications, give a 30% dose reduction of that one, give a 50% dose reduction of that one, 60% for this guy over here. Okay, so we have these quantitative mechanisms to help you incorporate this in a more actionable way. Paroxetine looks the same way. Now let's talk about the serotonin transporter. I mentioned that a few minutes ago, that if you have a variant in the serotonin transporter, you make less of that transporter, you're less likely to experience benefit from SSRI-based therapies. So the genetic variant is actually a deletion of part of the gene. So we call that the short form. Literally, we look at it on a gel, and it's a shorter band of DNA than the long version. It's really, really interesting nomenclature, right? Okay, so the patients who carry the S version or a version called the LG, which is a variant within the long form of the gene that actually obliterates that portion of the gene. Obliterates the function of it. So the LG patients actually act just like the short patients. So if they have one of these versions of the gene, they are considered poor responders. These are the folks who are least likely to experience benefit. And what the meta-analyses over the last couple of years have demonstrated over thousands and thousands of patients, 15 different papers across 2 different continents, what we have demonstrated is that patients with that version are essentially resistant. These patients are over 2-fold more likely to fail SSRIs. They don't respond adequately. They don't respond within the first 4 weeks, definitely. And they're less likely to achieve remission of symptoms. Another meta-analysis in 2010 actually looked at not just the outcomes of response and remission, but actually at adverse drug reactions associated with SSRIs. And these folks actually have a 2-fold increased risk of experiencing adverse reactions when they are treated with an SSRI. Now, the other side of the coin, the patients who have this LA version of the gene, homozygotes for that version of the gene are the ones who should be considered for the SSRI. These are the ones with the greatest likelihood of efficacy. These are the folks that are going to respond within the first 4 weeks of therapy. If they haven't responded within the first 4 weeks of therapy, they may very well be a 2D6 ultra-rapid metabolizer, and they just need an increased dose. Okay? So that is sort of the pharmacodynamic side of SSRIs. So when we think about treatment-resistant depression and the sheer number of patients who exhibit that phenotype, we also understand that with treatment-resistant depression comes an increased number of prescriptions concomitantly prescribed for those patients. These patients are over twice as likely to be hospitalized at least once during their depression. And they have anywhere from 7 to 19 times the costs, depending on the study you read, for treatment for these patients. Some of them go through 8 trials before they finally begin to stabilize. So we think about the continuum of risk with the 2 types of pharmacokinetic and pharmacodynamic biomarkers that we can now help identify risks. We look at a patient according to the APA guidelines for treatment of depression. Their first line prescription is usually an SSRI. About 75% of the time that first antidepressant falls into that category. Over the next 4 to 8 weeks, according to treatment guidelines, you would be titrating that initial prescription dosage based on the patient's response as well as their tolerance levels. So if they responded at all, you might actually try increasing the dose. If they haven't responded at all, you might try increasing the dose for another few weeks and then decide to either augment or actually switch them altogether. We understand, though, that 25% of the population are poor responders. That serotonin transport, 25% of all of us don't make enough transporter to adequately respond to an SSRI. Another 50% of us are heterozygotes for that gene, which means we fall into that intermediate category. We're not normal, we're not completely deficient, we sort of have that gray zone of risk. Some people can respond, but if you're an intermediate responder, you're probably, if you are going to respond at all, you're probably going to respond much longer than that first 4-week interval. And we understand that anywhere up to 50% of patients are eventually going to be diagnosed as treatment refractory. So if we think about the cytochrome are going to help identify how to titrate dose or even if to titrate dose. So if that patient has responded at all to the medication and you understand that they are a 2D6 intermediate or poor metabolizer, you know you only have a very limited window for dose titration, dose escalation upward before they're at significantly increased risk of having a side effect. However, if you understand that the patient has the serotonin transporter variant, no dose titration is going to help. So that's where we can incorporate both of those genes, both of those biomarkers into the treatment continuum. What is the clinical question at hand? They responded, but they're a little blunted. Let's try a dose increase. Well, do they have a genetic deficiency that's going to make that a risky move for this particular patient? Do they have the serotonin transporter variant that causes them to be resistant to this drug to begin with? Just some economic implications. I've written a few papers out in the last few years that have demonstrated the significant burden of these patients. So mentioned this earlier, treatment-resistant depression can significantly increase costs anywhere from 7 to 19 times the costs to treat these folks. Hospitalization increases medical costs, obviously, and these patients are, like I said, twice as likely to be hospitalized. And there was a study out just in the last 2 years that demonstrated that prospective utilization of pharmacogenetics in patients with depression and schizophrenia being treated with these antidepressants, antipsychotics, can actually decrease the likelihood of adverse events, hospitalizations, and improve costs. Psychosis, same thing. Okay, so moving on to pain management. 120 million prescriptions for hydrocodone and oxycodone alone. Those are actually interesting medications. This is a list of common medications, common opioid medications that there are pharmacogenetic biomarkers for. Now the ones that have the little double asterisks here, those are prodrugs. Those are drugs that are in their parent form, basically inert, inactive. Their metabolite, produced in this case by 2D6, is the much more potent form, is the active form of that medication. So if you're a 2D6 poor metabolizer and you take a prodrug, you're not going to activate it. So when the prodrug is a pain management med, you're not going to receive therapeutic benefit from it. You may still be in pain. Some of the common prodrugs, hydrocodone, oxycodone, codeine, tramadol. In fact, there have been 2 FDA advisories just in the last year and a half for 2D6 ultra-rapid metabolizers taking codeine. Think about the opposite side of that coin. If you're an ultra-rapid metabolizer taking codeine, you produce more morphine per codeine dose than you're supposed to, and you can end up with morphine overdose. So a couple FDA advisories on that one. Morphine, hydromorphone, oxymorphone, those are the active drugs. Those are not metabolized by cytochromes. They're already the active form. So let's use codeine as that example. As I mentioned, prodrug has to be activated into its primary metabolite morphine by 2D6. It's only about 10% of a standard codeine dose actually produces the active morphine moiety. About 90% of a codeine dose goes from inactive codeine to inactive norcodeine. That pathway is essentially irrelevant in terms of efficacy, in terms of pain relief of that medication. It's the 2D6 that makes the difference. And morphine is the thing that then goes into the brain and binds to the mu opioid receptor, the mu1 receptor, to elicit analgesic effect. As I mentioned, the 2D6 poor metabolizers are the ones who are not going to make morphine. They're not going to receive therapeutic analgesia. The ultra-rapid metabolizers, on the other hand, are going to shunt more of the codeine dose into this pathway because it's clearing the drug faster. So they're going to make more morphine per codeine dose and end up with the toxic side effects. This is from a paper from our lab a few years ago looking at the production of hydromorphone, so the active component based on a standard hydrocodone dose in normal metabolizers here versus poor metabolizers. So here we can see the normal metabolizers, or extensive metabolizers, taking a standard hydrocodone dose will achieve therapeutic blood levels of hydromorphone, and you can see the poor metabolizers have a blunted production of that metabolite altogether. The FDA advisory. So this is an example of what a pharmacogenetic report might look like for you, incorporating the knowledge of the phenotype, so that poor metabolizer phenotype, for example, with 2D6, together with consensus-backed, peer-reviewed, publicly available literature, including those quantitative dose adjustment strategies that I mentioned earlier. So we know, and there are pharmacogenetic guidelines that dictate that if they are a poor metabolizer and they're being considered or are currently taking a prodrug, they should probably avoid that drug altogether due to a lack of efficacy. And what we would provide in our report, for example, is to demonstrate an alternative consideration that is not metabolized, not affected by that variant pathway. So, for example, you were considering giving hydrocodone to a patient who's a poor metabolizer. You may want to consider giving them hydromorphone or Dilaudid instead. In fact, when you're giving them hydrocodone to begin with, you're actually giving them hydromorphone. You're just expecting their liver to do the work. And in a poor metabolizer, their liver can't do that. Okay? So the other portion, I'm so sorry, guys. These buttons are too close together. Fat thumbs, I guess. So we also have an adjust dosage section where when we know something quantitative to say about a drug, this is consensus fact. This is publicly available information. If you have a patient who is a 2D6 poor metabolizer and you're considering giving them propafenone, you probably want to give them a 70% dose reduction of that medication, 70% below the standard, the conventional dose that you would otherwise consider for that patient. Okay? Let's talk about cardiovascular biomarkers. A lot of different ones in this particular pathway. Cardiovascular health is obviously a huge part of medicine. When we think about the genes that we have, or the biomarkers that we have available, the cytochromes, of course, for the metabolic activities of these drugs. But we also have the vitamin K epoxide reductase enzyme, which is the target of warfarin inhibition. That one's got a genetic variant in it. 3A4, another cytochrome. SLCO1B1, that's a transporter for statins. If you have a variant in that transporter, they don't bind the statins in the blood and they can't transport it into the liver where they then get detoxified, cleared. So patients who have a variant in that transporter actually are at increased risk, significant increased risk of statin-induced myopathy. Okay. When we think about clopidogrel or Plavix, that one's a prodrug, just like those opioids. It has to be activated by cytochrome P452C19 to elicit the desired antiplatelet effect. There are about 30% of patients who have a genetic deficiency in 2C19. That means they don't adequately activate a standard clopidogrel dose. The poor metabolizers, the ones who have 2 completely inactive copies, are the ones who are most at risk of having residual high platelet reactivity and coronary events, stroke, MI, stent thromboses, death. And another about 25 to 28% of patients are going to fall into that intermediate range. That looks interesting. Sorry about that. What we're supposed to be looking at here are the phenotypes. So normal metabolizers, intermediate metabolizers, poor metabolizers. And this was from JAMA a couple of years ago. This was some of the data that actually led the FDA to relabel, to put the box warning on Plavix and now generic clopidogrel for the avoidance of clopidogrel in these poor metabolizers. You can see the risk of cardiovascular events and stent thromboses in sort of your baseline population. So this is the normalized risk, the normal risk level for these events in patients treated with clopidogrel for whom we don't know their genotypes. When you split out the genotypes, you can see that it's the intermediate and especially the poor metabolizers who have that 4 or 5, almost 5% increased residual risk associated with these. And there are 2 or 3 other papers from JAMA in that same time frame that demonstrate this elevated risk. A couple papers in the last year have tried to look at increasing dosages of clopidogrel in at least intermediate metabolizers to see if we could boost the generation of that active moiety so that they get into the therapeutic range. What we're looking at here are normal metabolizers, intermediate metabolizers, and poor metabolizers all the way on the right. The green line essentially represents the amount of platelet reactivity or platelet inhibition that is consistent with the therapeutic range. And if you look at a 75 milligram standard clopidogrel dose in a normal metabolizer, you're right in the therapeutic range of platelet inhibition. But when you get 75 milligrams to an intermediate, they have roughly 10% increase and 15 to 20% increased platelet reactivity. These are the patients who are at risk of failing the therapy. If you increase the doses into 150, 225, you can actually shunt those intermediate metabolizers in some instances into therapeutic range. But it's not terribly reproducible at this point, so there aren't any guidelines that say if you're an intermediate metabolizer, give an increased dose. It's an option based on some of these studies, but it hasn't reached consensus at this point. The only consensus is that no matter what dose you give a poor metabolizer, they don't ever get into the therapeutic range and they should be considered for one of the alternatives. And that's what the box warning actually says. This was just from a International Pharmacogenetics Consortium guideline paper last year across the different phenotypes for 2C19 and what you would consider for a patient and their antiplatelet therapy. If they're a normal metabolizer or an EM, extensive metabolizer, they could be given standard dosing of clopidogrel. Now, about 25% of the population actually have an ultra-rapid metabolizer phenotype of clopidogrel. There is a hyper-metabolizer in that gene as well. There are no guidelines that say you should either decrease the dose of clopidogrel or that you should consider those ultra-rapid metabolizers for an alternative medication. They do demonstrate a slight to moderate increased risk of bleeding, but the reality is giving them Effient or prasugrel also has an increased risk of bleeding. So at this point, even giving the alternative to clopidogrel in these ultra-rapid metabolizers has not been demonstrated to be the safer alternative. So at this point, ultra-rapids and normal metabolizers of 2C19 should be considered for clopidogrel, and the intermediate and poor metabolizers should be considered for the alternative. Warfarin. We have 2 genes that affect warfarin. The metabolic side, that 2C9, is the cytochrome that metabolizes warfarin into its inactive component. And I mentioned the V-core, the receptor target for for warfarin as well. Warfarin's been the poster child for pharmacogenetics for a lot of years, and there is a lot of controversy in the literature about what outcomes you can really expect with warfarin. We think the crux of warfarin genotyping is understanding how the metabolic side of this coin, of this drug, can be affected by genetic variants. This is modeling. You saw these models before. Remember the cytochromes. This is a good way to model those deficiencies. A standard dose of 5 milligram per day dose in a patient who's a normal metabolizer of that 2C9 will get into the therapeutic range. This yellow line is basically the S-warfarin concentration in the blood that is equivalent to an INR between 2 and 3. So consider the yellow line an INR of about 2.5. Okay? You give a patient a 5 milligram per day dose who's a normal metabolizer, and they'll get into the therapeutic range in 4, 5, 6 days. And they're stable in the therapeutic range. They have reached steady state by about day 5, day 6. Normal half-life of warfarin is about a day, so it's going to take 5 to 7 days to reach steady state in those patients. Conversely, the intermediate metabolizers and even going into the poor metabolizers of this gene, taking the same 5 milligram per day dose, first of all, you see that they're going to have 2, 3, 4 times the blood concentrations if they were allowed to stay on that dose for that protracted several-week period. But the more subtle thing is understanding how much longer it takes for those blood concentrations to reach those steady state levels, how much longer it takes for the blood concentrations to equilibrate. If you measure an INR when the blood concentrations are still transitioning upward, what does that mean for the INR? The INR is still going to go upward. But when you're getting that INR today, are you asking the question, is this INR likely to be moving? Are the blood concentrations likely to still be transitioning, moving? Or are you assuming that that blood concentration is stable, and therefore that INR is stable, and you should make a decision about dosing based on that? Well, as it turns out, normal practice, standard practice is you give them a dose, you give them about a week, you bring them back in 5 to 7 days, and you check that INR. If the INR is out of range, you make a decision to do something about that, either increase the dose or decrease the dose on that day 7. Well, when you look at, that first week, all of these blood concentrations in these different genetic variants are all pretty on top of each other. They all might actually be in the therapeutic INR range. The difference is this guy's staying in the therapeutic range. These guys aren't even halfway to where they're going to end up. So if you bring this patient back 2 weeks later, he's going to be super therapeutic. And you're going to wonder, well, you were therapeutic last week. What happened? So that's the biggest piece of the warfarin puzzle in our minds, is understanding that the delay in the time to reach steady state is very significant in these 2C9 deficient patients. It's not that you can't find the ultimate dose for these patients. It's that it could take you 3 months to chase supertherapeutic, subtherapeutic, supertherapeutic, subtherapeutic. And data consistently demonstrates that patients with these genetic variants take 3 months longer to stabilize. They're 4 times more likely to have a bleed in the initiation phase. They're 6 times more likely to demonstrate supertherapeutic INRs. But it takes 3 times longer to stabilize them. And that's largely because of the misunderstanding that these guys in 7 days are going to be stable. And these guys could take 2 weeks. These guys can take 3 weeks. And in rare cases, there are a couple genotypes where it takes 42 days for them to equilibrate to that steady state. So think about how long it would take for you to understand, how long it would take to understand that that INR is actually finally stopped. It's finally stopped moving. Okay. Again, the other side of warfarin is understanding the sensitivity rate, that efficacy boundary for patients based on the VCOR. If you have the VCOR variant, the genetic variant of VCOR, it means you produce less VCOR. If you have less VCOR, you simply need less warfarin to inhibit it. So patients with that VCOR variant are the truest warfarin-sensitive patients. They are the ones that need the lowest average doses. and this was from a paper in our laboratory a few years ago, patients with the genetic variant need the, sorry, that's a little misaligned, need the least amount of warfarin per day to achieve the therapeutic INR. These guys take 2.7 milligrams a day. These guys take roughly 5 milligrams per day, which about 50% of the population falls into this genotypic category. Makes sense that half the population are going to be around 5 milligrams. And then another 25% of the population are going to need upwards of 7 milligrams per day, just based on this B Corp. Okay, so that's going to help us understand who is truly warfarin sensitive at the get-go, who is not warfarin sensitive. This was an interesting patient we had a few years ago. Real patient, elderly woman, she was in her 60s, had begun a standard warfarin dose, about 5 milligrams per day for the first few days. And if you look here, we have blood concentrations on the left, which are the blue lines, but ignore those for a minute. On the right axis, we have INR, as demonstrated by the gold boxes. And the INR 2 and 3 is sort of that yellow shaded area there in the middle. As a practitioner, not using genetics, you actually have the INR, and that's basically what you have to measure this patient against for proper anticoagulation. So she started taking 5 milligrams per day for the first few days, and they got a couple INRs in those first few days, and they were subtherapeutic. And then on about day 4, day 5, her INR finally responded, and she was at an INR of 4. Held the dose a couple days. She dropped below therapeutic, below 2. 5 milligrams per day was too much, so they started alternating 2, 3 milligrams per day. And they brought her back over the course of the next week and a half, and she had 3 INRs basically in the therapeutic range. Said, okay, alternating 2 and 3, about 2.5 a day is what you need. Come back and see me in another week or so. She came back in another week and a half or so, and her INR was 4.5. They hold the dose for a day or two. She comes back, her INR is still 3. They decide to hold the dose another day. Now her INR is subtherapeutic again. 2 and 3 was too much, so we're going to start you on 2 milligrams per day. And lo and behold, that's finally the dose that stabilized her in the therapeutic range. But it took them until day 50 for her to actually stabilize consistently, to truly stabilize. Now we overlay the blood concentrations based on this patient's genotype. We got her blood in about that day 50 range, day 40, day 50, and we genotyped her, and she has one of those cytochrome variants. So she has a decreased time to reach steady state, so she's going to accumulate longer and slower. So we see now that her blood concentrations were much too high as she was initiated on 5. We watched the blood concentrations fall to below therapeutic levels when she had those doses held. And we can see that even though she had those, basically those 3 INRs right there popping into the therapeutic range over that week and a half, if we look at the blood concentrations, they were still transitioning upward. They had 2 weeks while they were still rising, while the INR was technically still in the therapeutic range. We sort of think about that like the honeymoon period. Her INR is in the therapeutic range, but it's not stable. Okay, and that's what we can see with the genetically modeled, with the genetic knowledge and the modeling of these as warfarin concentrations after the fact. When she had her high INR and they held it for a couple of days and it was 3, unfortunately what we see here is that her blood concentrations on that day were probably right in the therapeutic range. If they had restarted her right there, they probably could have gotten her stable about 15 days sooner than that. Okay? So again, it's not that we can, now our genotype, we can estimate a dose requirement for a patient based on the genotypes, based on their age, their gender, their weight, whether they take amiodarone, whether they smoke, what their target INR is. That's a state-of-the-art thing that we can provide. Lots of other laboratories can provide you mechanisms to estimate that maintenance dose for warfarin. And we said that she was probably in the 2.2 range, and she was 2.0. And that's good, and that's helpful at the beginning of a patient's therapy when you don't know whether they need 2 milligrams or they need 5 milligrams or they need 10 milligrams per day. It's good to understand how you can hone in on that. But it's a dose estimate. It's it's going to be right about 80% of the time. Do it, I don't know, less than 2 milligrams a day you can hone in on. But it's not perfect. It doesn't take into account every possible variable that affects warfarin dose requirement. But it takes into account a lot. We really do think the more important thing about warfarin genetics is being able to understand when the INR that you're using every day as standard of care practice is stable or not. So when you get an INR, right now you ask the question, is this INR in the therapeutic range? And the paradigm shift is looking at that INR and asking the question first, is this INR representative of steady state blood concentrations? Is it stable? And then you ask the question, is it therapeutic? And that's the way you can better use the INR to interpret the state of that patient and whether you're going to make a dose decision, a dose change at that time. So again, just in summary, we think that the opportunity of pharmacogenetics at this point is immense. It's really sort of on a hockey stick of the information we have now. A lot of clinical trials have just been completed just in the last couple of years that really are demonstrating significant advantages in using this type of data. And we think that it can be incorporated into the current standard of care. It doesn't replace the current standard of care. Using warfarin genetics doesn't replace the need for INR. It better informs the use of the INR. Use of 2D6 genotyping or serotonin transporter genotyping to pick the best antidepressant at the best dose for a given patient doesn't replace your standard of care. It simply enhances the information that you have at your disposal to make the best possible decisions to personalize that therapy for that patient. We think it's really important to note that a lot of these pharmacogenetic markers not only are associated with most common adverse drug reaction medications, but also things that are used in chronic medical management. And we may really have a great opportunity to be looking at pharmacogenetics, MTMs, or medication therapy management clinic opportunities to be able to incorporate these things into chronic disease management, decrease costs, improve outcomes. And with that, I'd like to take any questions.
Thank you very much. That was very good. Really outstanding work, and I really appreciate this, and I think there's a lot of discussions that we should have offline about how do we take the opportunity of having such wonderful clinicians in the audience to begin to move into this field to better take care of our patients, but also bring sort of uniqueness to what this organization does. But I have a bigger question for you, and I want your comments on this. How do you move precision, personalized, individualized medicine to population medicine? In other words, how do you bring this knowledge, which I can exert by seeing my patient tomorrow afternoon, as opposed to the president of AAIM making a blanket statement about the utilization of this technology, and what kind of data do we need for that to happen? Well, for example, how many clinical trials are looking at 1,000 patients where we look at genetics to determine outcomes versus we're not going to look at genetics, we're going to use the typical INR and see I can get to the right dose with one approach than the other, but the outcome may be the same. Mm-hmm. Same problem, same number of hospitalizations. I don't know that that's true, by the way. Is there enough data now to move to population medicine?
That's a great,
with this approach.
Right, that's a great question. I think it's a little bit drug-centric, so we can't classify all of them together. I would translate what you just said into how do we decide who to test? Are you saying that every single person who would be considered for clopidogrel should be tested? And indeed, the data says no. It's most applicable to the patients who are at the highest risk of having thrombotic events, even while taking Plavix. Those are ACS patients undergoing, who've already undergone or about to undergo PCI. It's not for the broad population who are treated with clopidogrel. And we have a lot of other sort of who to test algorithms. We wouldn't necessarily say that every single person who's ever going to go on a pain management medication would need to be genotyped for 2D6. So how would we help you in your population, in your care paradigm, decide who to test? Maybe it's just patients who are about to be prescribed one of those prodrugs. Maybe it's a person who's already failed a prodrug and you're about to put on another prodrug. That's another standard practice in pain management. So we have actually at PGXL, I've been working a lot on developing sort of the personalized medicine program, which is a full implementation strategy. It's understanding where the outcomes data is and where it isn't. Understanding that there are some populations of patients who this testing applies to in its entirety and other subpopulations that only applies to certain conditions or certain drugs.
Okay. Questions? Yes, sir.
From a health policy standpoint, this is one element of something that may impact drug levels and such. Renal function, liver function, green leafy vegetables, other things may impact on that too. So would I put my dollars here, or would I put it in therapeutic drug monitoring?
It's a great question. Again, pretty broad when you talk about medications overall. For drugs that we have therapeutic monitoring for, the good news is that therapeutic drug monitoring or urine drug testing for pain management clinics, for example, are a snapshot in time. Getting the picture of that drug level in the blood today may or may not be indicative of the genetic baseline. So we describe these genetics as setting the baseline. If you're an extensive metabolizer, you have residual metabolic activity. But what if you're taking an inhibitor together with that drug that you're doing therapeutic drug monitoring for, and the drug level is really, really high? Is that because they're a genetic poor metabolizer, or is that because of the inhibiting drug that they're taking at the same time? Because one of them you can do something about, and the other one you can't. So we get back to that mechanism of effect. So again, depending on the drug we're talking about, therapeutic drug management and pharmacogenetics are adjunctive to each other. One informs the other. But they don't, neither replaces the other. Neither replaces the other.
Is there a downside to genotyping people for this? I mean, it's probably, I can just say from my clinic, I probably don't have anybody in my clinic who is not on some medication. I mean, just
right.
Most of them are on 5, 6, or 11.
Mm-hmm.
I mean, to me, it would be really quite useful if I had a list that said, you know, this genotype suggests so-and-so would be more likely to develop toxicity from blank drugs, you know, less likely to respond to. I mean, it doesn't mean that I would never try them.
Sure.
But just knowing in advance that maybe I should be more vigilant.
Right, right.
Tell me.
Right. And absolutely. And in the case of the patients who, the majority of the patients are taking multiple medications at the same time, and you have an adverse event, what caused it? What variable can you remove? In practice today, what do? Start taking some of them away and see if it resolves? Is that really the mechanism of effect? This is what it allows us to understand. If you have a patient on 5 meds, but you knew ahead of time that he was a poor metabolizer of one particular system, that's going to allow you to hone in much faster on where the ADR is likely occurring. It also can inform drug-drug interactions. A big one is PPIs and clopidogrel. They're a no-no together because PPIs can inhibit the activation of Plavix through 2C19. PPIs inhibit 2C19. Well, if you have 2C19 residual activity because you're a genetic normal metabolizer, that interaction is appropriate, is possible. But if you're a genetic poor metabolizer, there is no such thing as PPIs inhibiting no activity. So that interaction becomes sort of null and void. And the bigger issue is that they're a genetic poor metabolizer. So that makes a big difference in what you would consider for that patient.
Yes, sir.
I'm a little bit more skeptical. I certainly believe that evidence-based medicine is not just using medicine when we that we have direct evidence for, but it's the best available evidence. And sometimes that's pharmacogenetics and pharmacodynamics. But I think we need to be careful. I mean, the metabolism of the drugs are more complicated than just 2C9 or 2C19 or any of these cytochromes alone. And I think that the PPI, clopidogrel, is a good example because, and I guess pharmacogenetics, what it comes down to are intermediate outcomes. They're not what we truly care about, which is events in patients. And there's a difference between observational data and randomized controlled trial, and at least in the only randomized controlled trial where PPI was randomized, patients were randomized to the use of it, were taking Plavix, it didn't make a difference on the outcomes. And so the story is probably more complicated, and knowing when we're going to make a therapeutic decision based on pharmacogenetics or pharmacodynamics, I think is complicated, and maybe, and as certainly you've said, is drug specific and maybe premature for many of the things, even some of the things I think that are recommended, you know, the Vigatran and a dose reduction to 75 milligrams based on renal function that's never been tested in any sort of outcome trial is worrisome to me. So maybe you should respond to, you know, how do you balance the best available data, what are appropriate intermediate targets, as opposed to waiting for true.
The final outcome, right? That huge adverse drug reaction. Very well said. Relative to the PPI example, I think part of the problem is those trials looking at that interaction potential don't all use genotyping as the baseline. So we can have a lot of noise in that system when we don't understand the fundamental pharmacogenetics are altered in 30% of those patients.
But until we have that information, should we be making clinical decisions based on that, or should we say the randomized controlled trials are best available data at this time?
I think you have the opportunity to look at using pharmacogenetics for certain patients and decide whether or not that's going to be a value add or not. If ultimately the question is clopidogrel the right choice for this patient, and the PPI is to balance the side effects of the first medication, then you first should ask the question, in my opinion. Your first responsibility would be, is the first drug I'm picking the efficacious one? And so that's where the genetics can set the baseline for that part of the clinical question. But you're absolutely right with looking at the intermediate outcomes. We describe a lot of those in the warfarin literature as sort of clinical efficiencies. Huge, serious bleeding events and strokes in these patients they do happen. They're relatively rare, considering how many people are on warfarin, and the trials aren't powered to assess whether genotyping can improve ADR rates. But they are powered to do things like pick up differences in time to reach therapeutic range, time spent in range, a lot of those more intermediate steps that we know can help improve warfarin management long term. So I think you're right. I think we do have to look at sort of a drug-specific, biomarker-specific interaction and decide where the intermediate outcomes are and where that best level of evidence exists to decide whether the genetics actually improve decision-making.
Yeah, if I may, I
Sure.
to add your answer was excellent, and I think that by focusing first on clopidogrel and then asking the drug interaction question, the drug interaction question, as you said, hasn't been quite as well sorted out, possibly because of design issues of how they ask that question. But certainly, the influence of the 2C9 deficiency on clopidogrel outcomes has been well established in prospective randomized controlled trials. You know, that's something that has been recognized by CMS for reimbursement and in the product label. So, you know, your comments about the drug interaction literature not being as solid is definitely truthful. And I think that your answer relative to, well, you know, let's first focus on the selection of the PPI, I think, or the
Antiplatelet.
those says are pretty good.
Last
I could respond. The issue comes down to fully prove a hypothesis, you need to come full circle. So the relationship between 2C19 and intermediates, meaning platelet reactivity, is known, and that is shown. But adjusting that or making clinical decisions on that are not known. And maybe the relationship between 2C19 and cardiovascular outcomes is much more complicated than how it affects the metabolism of clopidogrel alone. In fact, it may be confounded by that, and it may be something else that is yet to be discovered and so forth. Because when you give higher doses of clopidogrel and you see better platelet reactivity, those patients do not have a reduction. They still remain at high risk for stent thrombosis and all these other things, although even though their platelet reactivity has fallen down. So I think the relationship is complicated to, I think that the CMS statement is premature.
Last question.
I have two quick questions, I hope. The first is...
Last question.
As a clinician, if I want to order a genetic profile, do I get, you've mentioned quite a few drugs, do I order it specifically for the drug I'm anticipating using, or do I get a report on everything? And then the second question, and the residents will not be surprised I'm asking this, how much does this cost?
Okay.
Because I would ask that.
Sure. So I'll take the first question first. Okay. So in my laboratory, we do orders based on gene. We also have panels. So we have the clopidogrel panel. We have a warfarin panel, so that for the very, very, very common drugs, which are usually the reason that someone is ordering that gene, they can order it basically by the drug. But we also have educational literature that says if you're considering an SSRI, this is the panel that you should be considering ordering. And here are all the drugs that would be affected or taken into account in that panel orderable. Okay? So it just sort of depends on what the clinical question is. Do you have one specific question? The patient just had an ADR to this drug? Or are you treating that newly depressed patient and you're considering them for something for one of 10 drugs in a given class? And we can provide that level of information. Does that answer the first one?
Yes.
Okay. The cost is variable depending on the gene. A rule of thumb is there are a couple $100s per gene. Some of them are less than $100. Some of them are a little more than $200.
Okay. Well, again, thank you so much for bringing this important topic to us. I want to leave you guys with a thought here, and that is that if you saw the issue in JAMA from November that focused entirely on healthcare and healthcare crisis and healthcare costs, one of the authors made a very strong point that one of the problems we have with costs is this idea that we physicians have been trained over the past decades of being very individual. In other words, we want to have the authority and the opportunity to decide whatever we need to do for a particular patient. And patients feel the same way. They want to have the authority and the ability to control how they are treated as individuals. And that is one of the reasons why costs continue to go up, because we treat everybody as a very different person, and that populations should be moving, or I guess the United States, his argument should be that we should be moving into more population health, standardization of care, that will be the only way to decrease costs. So this concept is beginning to be, is the way I was raised, and yet is beginning to be at odds to what we're going to see over the next few decades. And finding that balance to provide the best care to our patients is going to be quite intriguing, quite interesting to watch. So you're from Louisville, okay? So you may have one of these. But we try to give a gift to everybody who's not from the Department of Medicine, and hopefully if you have one of these, it doesn't have your name on it.
My husband has one.
Okay,
There you go.
so good. So now you can battle him at equal footing. To Kristen, Reynolds, Medicine Ground Rounds, University of Louisville, January 23, 2014. Thank you so much for coming.
Thank you very much.
Thank you, everybody.
Thank you. Thank you.
We're trying to get everybody. everybody across the country to have a bat delivered, a slugger bat at some place. So far we have about half of the institutions